Hi guys, I'm Dr Allan Matthews. I am a dentist working at Integrated Dentalcare in Edinburgh, and today I wanted to talk a little bit about a really interesting case that I did, how we went about doing it, and how we gave this wonderful gentleman back his smile. So, straight to it. This was the presenting dentition. Now, as you can see, there are quite a few issues that are present here. We've got some wear, we've got some decay, we've got some gingivitis, although generally not terrible, and we have missing teeth. What this means is that this patient has lost vertical height to his bite, and the bottom jaw is protruding forwards, and we're just getting this worsening wear condition. Really important in cases like these is how you go about diagnosing the problems that are there, and then working out a kind of roadmap to how you're going to restore a dentition like this. So creating a problem list can be quite a beneficial thing to do. As I've already said, decay, loss of vertical height, a protrusive bite moving his jaw forwards. He had some ill-fitting dentures which would have been impacting on his occlusion. And his gingival health. He had quite a destructive occlusion, there was no protective elements that were there because there were teeth that he'd lost. The missing teeth themselves, meaning a reduction in posterior support, and of course the gingivitis, which we talked about, could potentially have been contributed to by the old ill-fitting dentures. How do we go about addressing a case like this? Now, I think it's really important not to rush straight to the finish line. It can be really tempting sometimes just to say, we're going to do all of this right now when you're finished. And I think it's almost quite important to make that more of a journey where you stabilize the dentition, eliminate as many of the health concerns as possible, and then you enter the restorative phase, but you try to test it as much as you can. You don't know how someone's going to tolerate what you've done. You don't know if what you've done will tolerate the person. You don't know if your work is going to break or fail earlier than expected. So it's important to try and take things slow and not rush it too much. As I've said in this slide, we're looking to stabilize first, addressing the gingivitis and the decay mainly. Design and test the new occlusion. And then once that has been tested and we've verified that it looks the part and it's functioning well, we can convert it to definitive restorative. It does not stop there. It's really important to review what you've done long term and try to make the patient aware that this is a long-term commitment that they're doing. They're not just wanting to disappear from your practice once it's completed. You want to keep an eye on things, and if anything happens, you want to be able to react to that at an early stage instead of them reappearing 15 years later where everything's trashed. Designing the prosthetic. Now, on this slide, I literally just took some photos, some occlusal shots, and I drew on it on the PC. And what I was trying to do was I was trying to design what I wanted his dentures to be like and how I wanted the upper crowns to marry up to those dentures. I wanted to design it all at the same time with the intention of trying to minimize the need for clasps and to try and maximize retention and stability. In the same way, we had a problem with his current dentures where they were covering the junction point between the teeth and the gum, and in doing so they would have impacted his gingival health, so we didn't want that if possible from the new designs. So how do we proceed? Remove the decay, place composite where indicated or temporary crowns where indicated, along with a testing denture. Hygiene intervention and guidance. The lower arch, we completed any restorations in composite and we put a chrome denture in, whereas in the upper it was temporary upper denture with temporary crowns, just so we could have at least a brief period of testing what the occlusion was going to do and then converting it to definitive. In terms of challenges that we expected to face along the way, there's the tolerance of the provisional work. It is never quite as good as the final stuff, and it's interesting to see how people react to having provisional work in their mouth as you go about changing things. Adherence to hygiene protocols is not always easy to clean around temporaries, or even sometimes dentition that has lost tissue over a long period of time, where it may be harder to clean in between and around teeth. The adaptive capacity of the TMJ and the musculature to changes in the vertical dimension. Now, this was probably the most important thing when it came to testing, was to make sure that when we opened up this person's bite, we wanted to check that it didn't suddenly start to generate symptoms, that we didn't start to get muscular discomfort or discomfort from the TMJ itself, depending on its adaptive ability. Parafunctional movements, of course, if somebody is bruxing, it's a real challenge because your work might not live as long as you would like it to, and you need to make these people aware that while you will try to idealize their occlusion as much as possible to mitigate the risk will still be there, and sometimes you'll need to react to what happens as time goes by. And then, of course, the adherence to the maintenance schedule, which we've already talked about a little bit. It's important that these people attend for their follow-up, and you can make sure that you're helping to prevent anything from getting worse. Mocking it up. Now, this was really cool. I took some 3D scans with the Trios scanner of my patient's teeth. I sent it off to the lab, and I gave them a little bit of guidance as to what I was looking for. Now, I knew that the bottom arch was going to be relatively straightforward because we had a lot of the teeth there, and all we really needed from that denture was to fill in the spaces and to give us a relatively flat lower occlusal plane. All that it really took to get that one right was a little bit of planing of teeth where spaces were to try and parallelize the path of insertion, which meant that we had a better fitting denture without any kind of gaps around the edges of it. The upper, however, I advised the lab of the length I wanted the front teeth to be, and we'd aimed for around about 10 millimeters with these, so it was going to be a significant opening up, but still within the realms that it should be about right for my patient's face. Remember that the average central incisor that is not worn is usually in the region of 10 to 11 millimeters long. And we mocked it up. I got a digital mock-up made of the upper teeth to go against the lowers, and the intention was to transfer that to the mouth so that we could test it and see how it got on, and then make any changes to that we needed to, potentially scan that, and then use it as guidance for the final definitive work. So this was the testing phase. Apologies for the slightly less than tidy temporaries here, but we've got some temporary crowns on the upper centrals and the upper right lateral, and on the upper left premolar. We've also provided a temporary acrylic denture up here to kind of test this new occlusion. In the lower, we went straight to finish. We've got a chrome that's slotted in beautifully around those teeth, and that gave us this really nice kind of flat occlusal plane to which we could modify the uppers to get this new occlusal vertical dimension. After a period of testing with that, we found that it functioned fantastically well and we didn't actually need to modify anything. We moved forward to the definitive phase where we had some milled zirconia crowns placed on the teeth that I mentioned before. And here you can see the kind of slots and grooves that are present, ready for the denture to slot into. Once we'd fitted those, I adapted the acrylic prototype denture and I put that back in because we had issues with a little bit of denture stomatitis from this patient, and we didn't want to go straight to the chrome finish. Now, what this did, unfortunately, was introduce one or two errors in how the crowns and the denture would ultimately go together, but we managed to address that when it came to that stage. Final denture trial. So we've got the framework fitted really nicely amongst those teeth, and we've got the teeth mocked up in wax. Now, one of the things that I was less happy about was the gap that had appeared on this trial between the upper left 1 and the upper left 2, the central and the lateral respectively, and I was concerned that it was because I had not kept the distal line angle of the upper left central kind of parallel to the path of insertion. So I bounced this back to the lab and I said, is there anything that we can do about this? Are we going to be able to find the path of insertion with this that will allow us to hide that issue? And then we went to the final fit, and here it is in position. Now, obviously, with the bone loss around the upper right lateral incisor, we were always going to have a big discrepancy in terms of the gingival zenith here. But I think we managed to get a fairly nice result. If I was going to be critical, I'd say, you know, the teeth are the right colour, but the gum really isn't. I'm not in the habit of taking shade tabs and photos for gums. Perhaps this case has taught me that that might be a better thing to do, and I'd be interested to hear from others on how they might manage such a thing. My patient, however, was very happy with this and has since given us a glowing testimonial as to how he's been getting on, and I'm really looking forward to following up with him over time. What we designed, and just to show it here, was a protective guidance. So when we were sliding laterally, on the right hand side we had the canine guidance. On the left hand side it was a little bit more of a group function, as those teeth were slightly more worn. And we didn't really want to rock the boat too much with that. It seemed like it was sharing it quite well, and it would be less likely to cause any damage to the work that I'd carried out. There's also a little bit of a protective overjet. My patient is not occluding heavily on those crowns at the front, so the risk to those is lower as a result. At the fit appointment, you can see these pictures. We've taken some from the side just to get a little bit of an idea of what the smile looks like. I'm delighted with it. If we were being picky, on the upper left, distal to the premolar, there's a gap, but realistically, what can you do with such a gap when it's too small for a tooth to be placed, but too large to have either of the teeth either side be bulked out? And we chose to accept that space, and it doesn't, I feel, have a negative impact on this gentleman's smile. And then I know these pictures are a bit more blurry, but it kind of highlights the change that you can make for a patient like this over time. I was delighted to see the difference, and it made him look younger and it made him look happier. So this has been a real joy of a case to carry out. And as I say, I'm really looking forward long term to caring for this patient and making sure that what I've done stays put and continues to behave. So that's me. If there are any questions about this case, or anyone feels like discussing something similar, please do get in touch. It's been a real pleasure, and I look forward to posting more cases soon. Thank you.